So up next, I'd like to introduce Craig Wylie, who's an advanced life support paramedic, currently employed as the Director of the Western Cape Government Health Emergency Medical Service. During his 20 years in emergency medical services, he has progressed from a basic ambulance assistant to an emergency care practitioner, completing his National Diploma EMC and Bachelor EMC, an Advanced Diploma in Healthcare Management, and a Master of Philosophy in Emergency Medicine. That is a lot of educational tickets there, Craig. Again, like Els, where do you find the time to relax? Welcome along.
Hey, and thank you for the introduction. Probably more than what I deserve. Welcome to everyone listening tonight, and a special welcome to, firstly, welcome to the people that I've had the pleasure of meeting before. I saw a couple on the participant list, Dave Tingley from Australia. It's an amazing time in Sydney when we were there not too long ago. And then also a special welcome to our colleagues from South Africa. I saw a couple that's joined tonight, so thanks for that. So firstly, I think it's important to dispel a bit of a myth here. In South Africa, if we talk about a critical care paramedic, we're specifically talking about someone that specializes almost in interfacility transfers. And that's not really what I'm going to be talking about tonight. I want to give you a little bit more of an overview, deep dive into what Kristen has talked about just before me, and perhaps share a little bit of the research and investigation that we've done into our service to try and improve it going forward. Right. So firstly, if my slide wants to work, apologies. So firstly, I think context is key, and Edward alluded to it with his search and rescue presentation. What you see here is two neighboring neighborhoods in the Western Cape, in Cape Town where I stay. And this speaks to that private versus public split in our, specifically in our insurance market. So 16% of our population is insured, but 84% of our population is not insured. What makes this significant is the inequality in the amount of money that we spend on each of these population groups. So our GDP to health is around 8.4%, and 50% of that gets spent on our private healthcare, and 50% of that gets spent on our government healthcare. So now you can obviously see the inequality that still exists in that space. We're not saying that that the population that pays for healthcare is not entitled to it, but we are saying that we should narrow that inequality. And the Western Cape and the South African National Health Services is working very hard on it, working towards a national health insurance or a universal healthcare model at the moment, and we're hoping to implement that by 2030. Ambitious, but let's hope we get there. So if we talk about context, South Africa has got 9 provinces, Western Cape being one of them. Western Cape being, in terms of, and it was published the other day, in terms of ambulance services, probably one of the smaller ones, but serving one of the largest landmass that we have. So just quickly, the Western Cape, which Chris, I call it Chris, she's a friend, alluded to just now, is in the southwestern area of South Africa. I should know that as the director of the public service. We cover about 130,000 kilometer landmass with around 7 million. Our last consensus was in 2011, but they're estimating our population at 7 million at the moment. 4.5 million of those living in our Cape Metropole area, which is the small little part at the bottom when you see Table Mountain, where that lies. In my service, we've got at any given time about 120 ambulances available for operational use, and we've got a total of 1,400 a different level of paramedics, like Chris has said before, and we'll go a little bit deeper into that. Overall, we respond to 4,900 2,000 in the region responses every year, but we take quite a significantly more amount of calls than that. Of that, and Chris has spoken about this, around 1,680 is injuries. And of that, if my mind serves me correctly, Nassif is on the line, you're talking about 40% serious injuries. So this is quite significant. If you look at all my slides in the bottom right or somewhere on the screen, there will be a QR code. You're welcome to scan that, and that will lead you to or take you to the research paper that we found the information on. This one specifically was done by Nassif, who is on the call tonight. So well done on that one, Nassif. So I asked that you indulge me for a couple of minutes, just to set the context. Like we said, I want to play you a video to better let you understand what our practitioners, because those are the people that really deliver the service or deliver the service to the population, goes through on a day-to-day basis in South Africa.
The fear never goes away. You always have that fear. We all feel, you come to a point where you don't want to come to work anymore. At the end of the day, we're putting our lives at risk for somebody that we don't even know.
My partner was stabbed with a bottleneck, and they held the bottleneck to her throat. And at the same time, I'm trying to defend myself against these guys that's also stabbing against, wanting to stab me. And at one point I shouted, I said, you know what, just leave her alone and come get me. It was only a day after that I realized that things could have gotten so worse. I could have paid with my life. And these are the things that we need to deal with. You know, it's scenes like this that makes one, I mean, we're two, and these are people that knows the area. So you don't know who's innocent bystanders or who's just people that's trying to take a chance.
Always make sure that everything is locked.
Hello, ambulance.
So you can imagine that in an environment where our practitioners need to go out and on a daily basis, they actually fear for their safety, it becomes quite a strenuous work. And I think that's what Chris has also alluded to with we need to make sure we look after ourselves. Right. So with the context set, we are very big proponents of this emergency care systems framework, which was published by the WHO not too long ago. If I say not too long ago, probably now about 10 years, which kind of shows us the journey of the patient through the emergency care system as such. So what I'm going to do tonight is just touch on a couple of these aspects that we have been investing in and researching, investigating, and making sure that we do better at. And I think that's key, right? We can either be sad, we can be very good, or we can say that, listen, while we do stuff very, very, very well and not very well, we still have a system and we're still improving on it, which is key. Right. So firstly, we'll speak a little bit about the contact center that we have. So all our emergency calls get logged through a centralized contact center within the public service. The private services are integrated in that they can report their calls. We discuss stuff with each other, and we make sure that there's no double resources. What is unique about South Africa is that the private services actually respond to emergencies as well, which you don't normally see elsewhere in the world. So what our colleague Louis and the rest of us did here is We, like Chris has also said, have 11 official languages with multiple cultures that exist. So it's very difficult to take a ILCOR or international resuscitation guideline in terms of what your patient or the caller will say, and to bring that over into South Africa. We need to make sure that we know what our population will say to us when they need an ambulance and when they need it urgently. So what they did here is they looked at key descriptors that our population use to call for an ambulance for when something is wrong. So we went back, looked at cases, looked at calls, did some content analysis, and matched those with outcomes. And essentially, what we got from this is a set number of descriptives that our population will use in the majority of time that can be identified as serious cases that needs to be responded to. I think one of our previous speakers spoke about our over triage, under triage, and this is what we're trying to address there, is to get the right triage or the right response to the right people at the right time. Then on our next step is our bystanders. We've gone quite deep into trying to address the first responder, and I saw a comment earlier about Good Sam. So this is very similar, but what we're doing is we're going into the communities and training emergency first aid responders with a week-long first aid course, empowering them to be first aiders firstly, but then also empowering them to assist their communities. Like Chris has identified, as we've got red zones, which significantly increases our response times. So you'll have to go to a police station first, standby for an escort, which is a strained resource in South Africa as well, and can increase your response times quite significantly. What these emergency first aid responders do for us is they're able to get to the patient quickly, make the scene safe, which is important, as you've seen on the video, and then advise whether the ambulance is urgently needed, whether there's safety concerns for an ambulance, and so on. What is amazing is the photo that you see in front of you. These are, or three of the members in that photo are actually what we call in South Africa car guards, which are people that basically look after your cars if you've stopped them in outside shopping centers, in parking lots, and so on, which is quite an empowering part. But for us at EMS, this means emergency care getting to our patients quicker and in a more efficient way. Right, so as Chris has also said, trauma, big problem for us. You saw that 168,000 in 1 year responses, of which a big bulk is very serious cases. So what we've started to do is starting to actually investigate what is the outcomes for our population in what trauma and where. And this study that is headed up by one PI that works with me, our medical director, Shahim De Vries, and a prof from UK, Nikofi Malt Milan, is actually looking into a 6-year period of patients prospectively and looking at outcomes, procedures done, and what actually makes a difference for our patients in the Western Cape in South Africa. And we're hoping that with this, we would be able to in future start changing practices to the benefit of our patients, right? And we'll talk a little bit about that just now as well. So happy to say we also have a medical rescue division. And in the middle of our biggest city, which is Cape Town, we've got this huge rock called Table Mountain. And we often do quite significant calls on this on Table Mountain of patients that's fallen, injured themselves, and so on. A colleague, Joe Park-Ross, did a 5-year review and found that the helicopter in its own was used around 100 times on the mountain per year. At the moment, and we're going into what we call our silly season, We're sitting with silly season, as in the tourism increases, so there's a lot more people on our mountain. We have already done 200 calls for the year of 2022. And after COVID, that seems to be the highest numbers that we've had even before COVID. On the left-hand side, you'll see a infrared picture, and that is our drone that we're currently using in our search and rescue environment. And we've had quite a couple of successes finding lost hikers, injured hikers in this manner. We also have other rescue. Very proud of our own crane in the ambulance service. And what was, we not too long ago, probably about 10 years ago, we did a rescue off the side of a bridge where a 18-wheeler's horse was hanging off the side of the bridge, and we lowered one of our practitioners into the cab of the horse to take the patient out off the side of this crane that you see at the back there. And then obviously we've got light motor vehicle rescue that we as the ambulance service do as well on a day-to-day basis. I think they sent me their statistics about a week ago, and they did around 326 responses in the month of November. Right, so a little bit about our training scope of practice. Chris has told us what we do or what our training is. So airway management has been a big debate in South Africa, and I think that's across the world in terms of non-physician performed pre-hospital intratracheal intubation. This is a paper that we did on 2018 data, where we looked at the different adverse events and success rates within South Africa and how intubation is being performed. Specifically, in South Africa, scope of practice is dictated by our Health Profession Council, which from our lowest level of medics, paramedics, have to register on a yearly basis, and that's also what governs our continuous improvement or our continuous development programs. Right, so a little bit more into the critical care interfacility world. Dave Stanton, that I saw in the call just now, was very involved in setting up this framework defining critical care retrieval services within the South African setting. And it's just a little bit about where we're working towards to define what we as South Africa are doing in terms of critical care retrieval in South Africa. So firstly, defining the patient population. I think Edward spoke a bit about that. Defining the case selection which we will need to go to, or which we need to send our critical care retrieval services to. Dedicated crew, which means dedicated training, dedicated equipment, and then quality management. And I think what is important to remember here is that although we spoke about the ECP or the different levels of training, there's yet to be a specialized training for critical care retrieval. And that kind of then speaks to this case definition. So this is just one article of quite a couple that you could come across. And I need to give credit here to Dr. Stassen, that is our PhD coordinator at UCT, the same PhD I'm on, so maybe I get some brownie points for calling his name out. But he is quite involved in the research to work towards formally defining and getting a critical care retrieval work group together. So this is a retrospective review that they did on neonates transported, but this was one private service. So it's not my service, and it's a national private service where they transported around 444 neonates over a year's period, of which 182 was ventilated as well. And these are also, as our colleagues in Canada paramedic-led team. So there are no physicians pre-hospitally. We do have consultant physicians, which we can consult, but they don't generally work pre-hospitally. Right, and then obviously just a shout out to our team. You can't do anything without your team, and they're key. Where do we want to go into the future? I think that EMS in South Africa, we're working really hard, like I said, to define our context, to understand what interventions that we get given in terms of best practice in the world really works for our population. We are working very quickly and very strongly towards enhancing our clinical support, specifically the clinical support that I think our colleagues from Queensland spoke about, where our cadres from EMS is actually providing that clinical support to their peers. I think researchability is always something you want to enhance. Obviously, in a strained environment such as us, like I said earlier, around 500,000 calls for 120 vehicles means that you're doing around 7 calls per shift. And that's, if you average it out, our normal days is around 14, and then we do get our off peak days as well. So you can imagine 14 responses in a 12-hour shift is quite a bit. And then I think lastly, it's for us, it's that addressing of the inequality gap, right? And our colleagues from Toronto said it key is your destination cannot be your outcome. So we've also got people that, or population and patients that live very far from our central hospitals. We've got 2 tertiary or 1 tertiary pediatric hospital, which can be anything up to 500, 550 kilometers away from where the patient gets injured. So we're working very hard at closing that gap. But yeah, so in South Africa as a whole, or in the Western Cape at least, I think we're making great strides towards meeting some of our first world cousins in providing an EMS service. And yeah, finally, just thank you to our team. Thanks, guys.
Craig, absolutely brilliant. That video was incredibly empowering. You know, but a lot, you know, I feel as a paramedic in the UK, you know, that again, I'm trying to think what the right word is, you know, that actually I take it for granted, you know, considering what the colleagues that you work with face. And just with that though, what kind of well-being support do they get? You know, I mean, the camaraderie must be off the scale amongst your team.
Yeah, thanks, Steve. I think we do a lot, but we don't do enough. The teams are very close to each other. They support each other very well. We've got formalized programs in place, well-being programs, employee assistance programs. But I do think that in any event, you can always do better when it comes to wellness. And there's definitely a focus for us in our service at the moment, because of the high rates of PTSD, the high rates of occupational injury as such, right? You know, you can throw stats out the whole day, but anything between 5 and 10% of our colleagues out there is off at any given time with some sort of traumatic injury, and that's not great.
And I mean, yeah, just simply incredible with it. And how do you find there is a big uptake in the role?
In which role?
In people wanting to working for the ambulance service?
Yeah. So yes, we still do have a lot of people that want to work for the ambulance services. Our training courses, like Chris has alluded to, is becoming more and more full. But you know, when you choose a career and you're starting off and you go, well, can I become a doctor or a paramedic? And yes, as a paramedic, you'll get half the salary, if that. Let's leave that out the window. But you know that the environment you're going to work at is so dangerous. Which one are you going to choose?
Yeah.
Right. You know that like in a couple of years, you won't be able to do it anymore because of the moral injury. Which one are you going to choose? So I think these are questions we have to ask ourselves, and we have to start addressing going forward into the future.
I think that, just what your presentation really highlights to me was not only the mental well-being for your staff, but actually the amount of research you're doing, which is absolutely fantastic. So I'd be generally really excited to see what the future holds, for yourself and your colleagues.
Yeah, no, definitely. And I think in terms of the research, you see that most of it is still descriptive. We are starting to move into the direction of experimental and prospective experimental studies, but it's a slow process with regulating systems or regulating frameworks. I won't say inhibiting it, but making it challenging. But we're working through it, and I think if all goes to plan, we should see our first RCT starting in South Africa in the pre-hospital settings by pre-hospital practitioners within the next year.
Absolutely amazing, Craig. And just one more note on that silly season. I can only envision that's down to tourism.
Yeah, but also down to our the major drive from injury, right, is irresponsible behavior.
Yeah,
and that's not just tourism; that's our own population as well.
I think that's a new term that will be adopted by a lot of countries. Listen, Craig, thank you ever so much for your time, and what a great presentation. You have a great